Good afternoon, everyone. It's a really good opportunity to be able to do this again because Jill's already had her inaugural lecture, but it was so good, we thought it was a really good thing to repeat it. And so it means that actually the jokes that I told the last time I probably won't tell again. I'll perhaps get some new ones. Her actual inaugural lecture, which happened in May, was basically that there was a huge number of people at the lecture, and lots of staff who couldn't get to it said afterwards it would have been really, really good if it had been videoed, filmed, so that we could share it with the students, but also show it to some of the staff who couldn't get there either. And as Jill goes through her presentation, you'll see why it's a pretty important lecture to be sharing with you as students in your second year and moving through your degree programme. I think some of the things that she's going to tell you about you probably won't be surprised at, but I think there's quite a lot of them that you will be surprised at. But it's definitely something we want you to share. So let me tell you a little bit about Jill Maben. This is what I get to do at the inaugural lectures, is tell you about the individual, a bit of the sort of personal side of the people that you see up in the school. So Jill joined the Florence Nightingale School of Nursing and Midwifery in 2007 as a senior research fellow and deputy director of the National Nursing Research Unit, which sits within the school. And then she was subsequently appointed as director of the NNIU in January 2011, and after that, in the September, she was awarded her personal chair. Under her leadership, the NNIU has continued to deliver high-quality research that helps to inform and shape policy and practice related to the nursing and the wider healthcare workforce. Last year, the NNIU celebrated the unit's 35th anniversary. So the unit has been supporting and assisting the Department of Health as well as a range of other organisations and institutions about policy and about workforce. Having said that, I think Jill would be the first to say that they haven't necessarily taken everything on board that she would have liked them to. Jill began her nursing career at Addenbrooke's Hospital in Cambridge. However, she's also an alumna of King's College London, having completed her MSc in nursing here. She started her PhD and then, for some reason unknown to us but known to Jill, she moved to the University of Southampton to finish it. I'd have to say it was because her supervisor moved there, so it seems a logical thing to do. But we drew her back in again. Jill's research interests focus largely on the healthcare and nursing workforce, and in particular the effects of staff well-being on patient experience and outcomes. Hence the reason why we think it's a lecture that you really want to hear. Her inaugural lecture will explore some of her research findings in this area and is particularly topical following the recent publication of the Francis Report into the Mid Staffordshire NHS Foundation Trust. Jill has been involved in several discussions and debates around the Francis Report recently and is using her research to help shape policy recommendations, such as minimum nurse staffing levels. I'm sure she will be happy to answer lots of your questions at the end of her lecture, which is entitled Care, Compassion and Ideals, Nurses' Experience of Nursing. So please join me in welcoming Jill Maben.
Thank you very much, Helen. I hope you can all hear me. Yes, great. It's fantastic to see all of you here, and I really am very honoured to be speaking to you as students because you'll hear throughout the presentation that a lot of my data came from student nurses at the end of their course, and it will be really good to hear your feedback and your views at the end. So as Helen said, I first delivered this lecture in May. It was an evening event, and inaugural lectures are slightly strange things in that you feel a little bit judged. You're up there, you've got your chair, you're a professor, and everyone's sitting there in the audience thinking, well, what do you know and what are you going to tell us then? And your family's there. My children were there, my husband, my sister, my friends, all sorts of things. So you're speaking to a very wide audience. My daughter's 14. I don't know if she knows a great deal about the Francis Report. She probably knows more than most 14-year-olds, given me. So it's quite a challenging thing to do, to actually make it quite academic, but also speak to a wider audience and make it understandable. So it's also, my view is that inaugural lectures are about your personal journey. So forgive me for indulging myself with a few old photographs of me, largely, because I've traced my experiences through this as well, my experiences of a nurse. So it is quite a personal journey. Okay, so you might expect me to start here, which some of you will know where that is, some of you won't know, but that is Stafford Hospital. And as we now know, that's where at least 400 and possibly as many as 1,200 patients died unnecessarily. And patients received very poor care over a period of at least 5 years from 2002. There's been a public inquiry, and there have been 2 reports by Robert Francis QC. In this one, the first, he reported a disturbing lack of compassion. And he noted a focus on finance and figures at the expense of patient care. This was underpinned by a preoccupation with a narrow set of top-down targets. This is Robert Francis himself, who I've had the opportunity to meet. I think he's a very passionate man about this and really cares, and we've been encouraging him to really consider the nursing issues, which I think he has in his report. So in February this year, he published his second report, which ran to 3 volumes. There they are in the corner there, so quite a hefty read. I haven't read every word, but I recommend volume 3 to you, which focuses on the nursing issues. And I actually recommend volume 1, because volume 1 is pretty harrowing, but it tells the patient stories. But volume 3 is really looking at the nursing issues and some of his nursing recommendations. He's a lawyer, and there were a lot of recommendations. There were 290. And this is recommendation 185, which I selected to talk about. And that says, as you can read, a selection of recruits to the profession who evidence the appropriate values, attitudes and behaviours, and the ability and motivation to enable them to put the welfare of others above their own interests. Pretty uncontroversial, you might say, and I'm certainly not here to defend poor patient care. Far from it. My work is all about ultimately improving patient care. And of course we want to recruit nurses with the appropriate values, attitudes and behaviours. But the underlying assumption, I think, here is that it's a key indicator of where things have gone wrong, particularly with nursing. But what if largely we haven't been getting recruitment wrong? What if we've recruited nurses with great values and nursing ideals, only for them to be dashed, eroded and crushed in a challenging practice environments? What if we haven't equipped staff well enough to do the difficult work asked of nurses every day in the NHS? So, as Helen said, this is the title of my lecture, Care, Compassion and Ideals, Nurses' Experiences of Nursing. So, have we been recruiting the wrong people? Well, I don't actually think we have. So I'm going to talk about care, compassion and ideals, and I'll be talking today, as I said, about my own personal journey before drawing on research over 20 years, focusing on 3 key projects, all of which have examined staff experiences of care. I'll contextualise these in national and international research findings before suggesting the next steps, what can be done. Here's first bit of the personal journey. That is me, long hair. This is me and my dad in the late 70s outside the nurses' home at what was then Old Addenbrooke's Hospital in Cambridge. There were no nurses in my family, yet I'd wanted to be a nurse for a very long time, probably since around the age of my daughter now, or at least 14. My father, who was a policeman, didn't want me to be a nurse. He wanted me to be a doctor. I remember distinctly him saying to me, nurses are skivvies and clear up after people, and he had aspirations for me to be a doctor, which was much more aspirational as far as he was concerned. I'm afraid I ignored him. I think we probably all ignore our parents. Hopefully my daughter won't ignore me, of course. And I entered nursing in 1979 with a very strong sense of compassion. Yet 2 years after qualifying, I left, and I thought never to return. So why was that? What happened to me and what went wrong? I did my nursing in Cambridge, and when you do it in Cambridge, they're very well set up to take these photographs because they do it for all the Cambridge colleges. So we had this photograph taken of my set. My set was about 60. We had 2 men in it then. And so I just qualified here at Addenbrooke's in 1982. That's me. I'm in the front row next to the teacher. And I probably know at least 4 of those people in that picture who are, interestingly, all still nursing. We did have a reunion relatively recently, and perhaps only those who were still nursing came back. But anyway, there were a significant number of us still doing it, and many still at the bedside. So in 1983, I moved to London, and I had my second staff nurse post. I'm going to tell you a story now. And 14 months later, as I said, I'd left nursing. And I thought it was for good. I was 22, and I was working on a busy 32-bedded male medical ward, and was often in charge of the whole ward. One evening, it was particularly busy, and Tom, a man in his 50s, was confused and also very frustrated as I went to take his blood pressure. He grabbed the metal spig. They were very heavy metal boxes in those days, and he got out of bed and threatened to throw it through the window. I got myself between him and the window, thinking it might stop him, at which point he said he'd throw it at me. There was only one other member of staff on the ward at the time, and they were calling security, who incidentally never came. If it was already a difficult situation, it then got much worse when the patient in the next bed, who was recovering from an MI he'd had 2 days earlier, got between me and Tom. At that stage, I didn't know if I was more worried about the spig going through the window, it hitting me, or Jack, my knight in shining armour, having another MI. After a 5-minute standoff, with me pleading with Jack to get back into bed, the spig did eventually go through the window. No one was hurt as such. My blood pressure returned to normal, and life on the ward carried on. But it was around that same time that 6 patients died in a single week. 2 unexpectedly from cardiac arrests, and another, Eddie, after coming in for diagnostic tests only 3 days earlier, seemingly well. I bonded well with him and his wife, and felt their bewilderment and their distress as he rapidly went downhill and died 3 days after admission from an inoperable cancer. Comforting Eileen, his wife, was impossible, but I tried. She came back to say thank you. She bought me a begonia, and she said I was kind. I didn't feel kind. I felt powerless, useless, bewildered, and quite frankly, out of my depth, both as a nurse and as a human being. The senior nurse found me crying in the sluice that week, told me to pull myself together and get back on the ward. 2 months later, I left. I had to get away from the stress, the distress, and quite frankly, the sense of failure. Staff in the NHS experience these feelings all the time, and having dipped my toe back into clinical practice recently, it certainly isn't an easier world. If anything, it's much more difficult. Yet to deliver compassionate care, staff need to keep in touch with their own humanity, which isn't always an easy feat. I don't think I was the wrong type of person, but I did leave nursing, and I went to university for the first time. I really did leave nursing right behind, and I studied history at UCL. It was in the good old days when you got a grant as an independent, and I was left with no debts. I could nurse in the holidays, and I had a great time, quite frankly, and it was excellent. And I just met different people, but I still kept nursing. I worked in care of older people settings, and as I said, could work in the holidays and do a few nights here and there, and left with no debts. But I actually did come back to nursing, obviously, standing here in front of you, and I found nursing again in Australia, where I spent a year while I was in the middle of a 2-year round-the-world trip. I worked here at the Royal Women's Hospital, which looked like this when I worked there, but now looks like this. Shame I wasn't there then. And there, what I found and what really turned me back onto nursing, I mean, I did work there because that's what I could do. I had those skills, and you can travel around the world with nursing. But I really felt valued. I felt supported. I was never left in charge in the 12 months I was there. I worked on a gynae oncology ward. And I undertook more courses in education to support good care delivery there in 12 months than I'd had in 2 years of the NHS. So it just gave me different messages. It just made me feel that I was valued in that society, that the organisation and my colleagues were supporting me and there to take care of me, both in terms of not leaving me in charge, but also in terms of supporting my development. So when I returned to the UK, I started work at King's here. I've been here twice, quite obviously. I was a research assistant in 1991, and I worked with 2 very famous professors of nursing. You may well have heard of them. One is Professor Dame Jill Maben, and the other is Professor Dame Jennifer Wilson Barnett. Jenny was head of school a couple of incarnations before Helen. And I came back and did a study there evaluating health promotion and health education in acute settings. And then an early evaluation of the new nursing courses, the Project 2000 courses. My master's thesis examined the transition experiences of newly qualified nurses and called for preceptorship, a period of support, which many of you will have heard of, still does exist. In that thesis in, I think it was 1996, quite a long time ago, I called for it to be made mandatory. It still isn't mandatory. And I think what happens then is that some places pay lip service to it, some good places don't, but some trusts pay lip service to it, and actually staff are not well supported going into clinical practice as newly qualified nurses. So unfortunately, it still isn't mandatory. My PhD didn't set out, it was called The Fate of Ideals and Values, Experiences of Newly Qualified Nurses. I didn't actually set out to examine that. I set out to examine how nurses implemented research findings into practice. And I did a bit of pilot work at the beginning, as one does in your research studies. And I went out and I shadowed nurses, and they told me some things, but they also said, that's not really what's going on for us here. We can put, there are these issues around research into practice, but these are the issues for us. This is what's going on for us. And what I found was this real conflict between, to some extent, what they'd been taught in their education in college and what they were practicing, what they were finding in practice in the ward. So there was this sort of theory-practice gap that many people have written about, but I've also written about. So I didn't actually study that. What I found, really, so I set out to examine how nurses found their value, what their values were at the end of the course, and how that translated into practice. It was a longitudinal study that I'm going to tell you quite a bit about now, and I'm going to share those findings, assuming the slides help me in a moment. But what I found from this work was most nurses enter the profession because they're motivated to. They're motivated by the ideals of altruism and a desire to make a difference in the lives of others. However, in some environments, a transformation occurs, so that over time, these same people are forced to abandon their ideals and protect themselves against a system that erodes humanity and caring. Individual nurses experience emotional exhaustion and burnout, their ideals are compromised or crushed, and feelings of compassion may be shut down. I'm really going to tell you quite a bit about this now. She says, hopefully. Yeah, great. So this is the study, this is what it involved. I asked students at the end of their course in a questionnaire, so that first top box, final year students in 3 schools of nursing. As a qualified nurse, what do you anticipate will be your ideals for practice? That is, if you were able to choose how to practice, what would be the kind of care you would like to give? I then followed up 26 of these students as they became qualified nurses, so 22 women and 4 men. I interviewed them, as you can see, between 4 and 6 months. They all carried on participating. I interviewed the same people again between 11 and 15 months. And then I did another postal questionnaire. And I also sent them their interview transcripts, which I think some of them found very alarming and some of them found very fascinating, looking back at the things they told me at interview 1 and interview 2. So I analysed what I called the fate of their ideals and values over this period. I wanted to understand what the experience was like for them and how this might change over time. And I identified 3 groups. This was my analysis, and so I identified 3 groups, which I called, these are my categories, sustained idealists, compromised idealists, and crushed idealists. So the sustained idealists were those who, because of good support, good role models, good staffing and skill mix, and a philosophy of care that promoted compassionate care, were able to retain their ideals. And there were just 4 out of the 26 nurses. Or there were the majority, as you can see, 40 in the compromised idealist group was the biggest group, and 8 who were crushed, whose ideals became compromised or crushed. And I'm going to draw on that data now to share some of the findings with you. So, newly qualified nurses emerged from the course with a strong set of values and ideals. And this was one example. I'd like to see the client as an individual, having time to support them in a holistic way, being able to pick up when they're worried or distressed, while at the same time ensuring their independence. So this is what people wrote in their questionnaires at the end of 3 years. This is how I want to nurse. There were these 3 broad categories, which were around patient-centred holistic care, quality care, and using nursing knowledge and research-based care. And so these are the kind of things people were saying as students. Now, drawing on this data, I actually want to tell you another story. And this time it's from one of my participants. Maria was one of the crushed idealist group. She didn't manage to retain her ideals. And some people, interestingly, they were certainly compromising by the first interview between 4 and 6 months. And you must remember these ideals were, in my terms, crushed by 15 to 18 months after first being qualified. So it's quite early. We're not talking 10 years down the line. This is relatively soon. So this, Maria said, just after 14 months in practice, and I quote, "I felt that I'd really compromised my belief in how dying people shouldn't be alone. I'm sure I definitely do compromise my ideals, like talking to patients rudely, that's one. And I would quite like to say, okay, rant and rave at me. I can sit here and I can take this. I've got half an hour to sit here with you. Once you've calmed down, we'll go through it. But you just haven't got that time." She went on to talk about a very busy night shift. "This woman just started screaming and screaming at the top of her voice. I still hadn't done my IVs and there were loads to do. I went in there and I just said, 'Will you be quiet for 5 minutes? Just be quiet. I'll shut the door and you can calm down and then I'll come back.' And as I shut the door, she really started screaming really loud. And the sister walked on and started saying, 'What do you think you're doing?' And I said, 'Okay, I know I'm wrong, but I'm at the end of my tether here. I really felt like I'd compromised myself then because I was so rude to this patient. And it was really bad and I shouldn't have been. That was horrible. I didn't even compromise my ideal. I lost one. I was just so tired and at the end of my tether.' And I think she, like me, had no real support from senior staff. So the ward sister came on, picked her up on it relatively reasonably, but then didn't offer support or enable her to manage that situation in a different way. And this is another quote from Anna at interview 1. And she said, "I feel quite sad that I'm not able to give my all to patient care all the time. I still want to. I do feel quite drained when I come in from work because I'm trying to sit down and talk with patients as well as get on with everything else I've got to do. That will probably get less and less as I get more experience." So you can see already at interview 1, she's beginning to kind of almost compromise and ration care because she recognises she can't do everything. And Heidi at interview 2 said, "Sometimes I'd go home thinking I didn't even see a patient today, you know, and it did feel like that sometimes, a terrible shift where all you've done is paperwork and drugs and that's it. You haven't even spoken to any of your patients. It wasn't care because you just didn't see them." And Ellen, again at interview 1, "I think staffing levels is a big one. There's nothing more frustrating than when you end a shift and you know you haven't cared very well for your patients. Staffing levels prevent you from doing that. You just run around doing the basic care. Very basic, which is just not on." So you can see these staff were very well aware that their compassion was being eroded and they weren't able to deliver the care they wanted to give and the impact of that on their patients. So Anna again said, "I'm slightly less compassionate than I perhaps would be if I was still a student, which is not a good thing. As a student, you're so much more on hand to sit with patients and hold their hands and talk to them." And Helena at interview 2 said, "When I'm really tired, I know I can feel myself. It's awful, knowing I'm different with the patients. But when you haven't got time and you're really busy, I know I'm just impatient with them and I just feel awful." So Diplomat's ideals were thwarted, I argued, through what I called structural and organisational constraints, beyond the control of individual nurses. Key thwarting factors, I suggested, were time pressures, role constraints, staff shortages, work overload, and through the organisation of nursing work in which care was task as opposed to patient-orientated. And if you remember, a lot of them talked at the beginning about wanting to be patient-orientated, give holistic care, but that wasn't the experience in practice. They were very much organised around tasks, and that really got in the way of them able to give the care they wanted to give. So here's a list of these issues. And as well as these organisational constraints, they were also what I called covert rules. So these were rules that my participants didn't really call them rules, but they kept talking about these things. Well, you do one thing, but actually really what staff want me to do is this other thing. And so I'm rewarded for doing this, but actually the philosophy of care on the wall at that time, it was often the philosophy of care was written on the wall and you could see that. But actually I'm rewarded for doing other things like making beds and doing tasks and getting through the work. And so these are what I called the covert rules. And rule 1, there were these 4 rules I identified. So it's the idea that sort of hurried physical care prevails. So there was so much physical work to do, you got through the work, and that was very much to the detriment of psychological care. Psychological care was often seen as an add-on or was somehow difficult to give in a way that the nurses wanted to give it. They couldn't answer patients' questions. And interestingly, recently, I don't know if you picked up any in the media, my colleagues from the National Nursing Research Unit were talking on the Today programme and in other media outlets around what we called missed care. And that's from a big national study recently called RN Forecast. And the missed care, the care that staff were having to miss off was often this same psychological care, supporting patients, listening to their worries, answering questions. And staff reported on their last shift not being able to do that. And that's now, today. This other rule I think is quite interesting, and I think this still prevails, certainly in acute care, this idea of doing a fair share of the work, this idea that you mustn't shirk, that you can't, it was difficult to hand over care not done to the next shift. It wasn't seen as a sort of team 24-hour, whole week or whole few days episode. It was like, well, I've been given all this in the morning, I've got to do it all. And so that fed into this hurried physical care prevails. There's an idea of getting through the work, but also that it was your responsibility to do it and you couldn't hand it over to someone else. And I think that leads into this idea of a sort of a good towards sister is one who's out on the ward rolling their sleeves up and giving care. So the very much an idea that, you know, nurses is a very practical profession and you need to be out there doing it, and if you're not, that was seen to be frowned upon. Rule 3, I think, was a really interesting one, given what everybody said they wanted to do, and really what they were told was, well, don't get involved with patients. It's all too difficult. You've really got to protect yourself. Keep an emotional distance. I remember one of my participants, he was one of the 2 men, he said, well, when the day comes when I don't get involved with patients or I keep an emotional distance will be when I go and get a job in the mortuary. You know, it's not what I've come here to do. And rule 4 was very much, I think it was perhaps a product, although I'm sure you would still feel it. I'd be interested to hear what you think of these. But I think it was very much a product. Project 2000, nurses were sort of felt to be this whole new curriculum, go out and change the world. There's a bit of evangelising, to be honest. You're all different nurses, go out there and you've got all the evidence and you've got lots of ideas that will be welcomed. So I think my participants felt great, you know, well, I've got all the research evidence, I know this, and I'm going to go out into practice and it'll be really welcomed. Everyone's going to say, oh, you tell us about the latest paper and what. That wasn't people's experience. It was very much an experience of calm down, don't tell us all that, don't want to hear it, fit in and don't rock the boat. On these challenging ward environments, as I said, 2 people sustained their ideals and they worked in environments where people were encouraged to share their ideas, and these covert rules didn't exist to the same degree. But if the covert rules were the messages, the colleagues in practice were the messengers, so they were the ones giving these messages to newly qualified staff. And what I feel, it wasn't that they were sort of, you know, it's not bad, good, different. They also had been socialised into this way of being. And this meant that they conveyed the expediency required to get the work done, often at the expense of individual patient needs, and were the antithesis of the ideals and values of the new nurses in my study. And so role models were really important, and negative role models, as I called them, and I think many of you will be able to identify this. You often can identify a nurse and think, okay, I know I really don't want to be like that. Somebody who's, you know, first out the door, not really caring about patients, whatever it is, or you know, perhaps is burnt out. You can see colleagues who are burnt out and you think, okay, I don't want to be like that. So these negative role models, they could be helpful in showing new nurses what they didn't want to be like. But if there were too many of those in the ward and not enough good role models, this could be very detrimental to them being able to nurse in the way they wanted to, because there was nothing to aspire to. You couldn't see a nurse where you thought, okay, that's what I want to be like. And one of my participants said, they said that I'd soon settle down and stop being so innovative. So this is what Anna said after 8 months. And she said, you know what the important things you have to do throughout the day, the drugs and things, and then you just organise yourself around that. And obviously that's important. You know, there are drugs to be given, they have to be given on time. But for her, you know, I think there was some dissonance for these nurses, because what she said, the first time I met her at the end of her education as a student, she considered her priority was helping my patients to cope or adjust to their illness or injury and facilitate their progress. It's nice to feel that you've made a difference to someone's day. So you can see in those 2 extracts, she had quite understandably become very pragmatic and had to some extent leave behind some of those ideals. And from this work, I identified what positive environments of care look like. So I drew on the whole data set, looked at where people had been facilitated to retain their ideals, and drew across some of the other data too, to identify that what was important were good role models, having motivated and receptive colleagues, adequate staff and a good skill mix, somewhere where ideas were welcomed and change was encouraged, where there was support for staff, mentorship and preceptorship, and a philosophy of care that supports compassionate care. So that was my PhD, and there's a bit more here about what I called the idealism journey. So what you can see across the top are the 3 groups, the sustained idealists, the compromised idealists, and the crushed. So as I've said, the sustained were able to retain their ideals, they could implement their ideals, and they remained enthusiastic and motivated. The compromised, and this was the group that was almost challenged the most, because they had still held on to their ideals that they couldn't do every day, and they had some challenges every day, so they'd adjusted them. Sometimes they could implement their ideals, and they were just surviving, and they were probably the most frustrated group actually, because by the time you got to the crushed group, they'd pretty much lost their ideals. They had to bury them, they had to put them somewhere else, because on a daily basis they couldn't meet them, couldn't implement them. And they were quite demotivated. And interestingly, when I sent them their transcripts, a lot of them looked back and said, I can see now how burnt out I was. I was really burnt out, looking back on the things I was saying. So I hope I'm not depressing you entirely here. And burnout leads to a loss of compassion and depersonalisation. And Janet said, I can see it happening already. I think it's just the fact that it's a very stressful environment. You can see yourself getting worn out, and your energy level depleting, and you're dissatisfied. You're just too busy to show people that you're being compassionate. And that's so important to patients. You just need to remember how every little thing you do is so frightening to them. But when you're tired, I don't think that I care any less. Sometimes I just haven't got the energy to show it. And that is at interview 1. And drawing on the literature, these authors, Pines and Aronson, would say burnout strikes precisely those individuals who had once been among the most idealistic and enthusiastic, and they would be more susceptible to the most severe burnout. We have found over and over again that to burn out, a person needs to have been on fire at one time. So 3 years after qualification, of the 26 students I interviewed, 2 had left nursing for good. 1 had gone to do an art degree. I went and did a history degree. And 2 had left for a while at least, and these were the so-called crushed idealists. This group and the compromised idealists, as I said, were the most likely to experience stress and burnout. And the proportion of doctors and other healthcare professionals showing above threshold levels of stress has remained constant at 28%, compared to the general working population of 18%. Of whom are above the threshold. So we know doctors and nurses are more likely to be stressed and burnt out than other working people. And as I said, I mentioned this EU-wide study that my colleagues in the National Nursing Research Unit had just been completing, and it was a 10-country-wide study across Europe. And in that, UK nurses were second only to recession-hit Greece in terms of the extent of their burnout. So the UK nurses are pretty burnt out across Europe compared to their European counterparts. 42% of English nurses surveyed were assessed as being burnt out, while 44% stated that they intended to leave their job in the next year due to dissatisfaction. And we know emotional exhaustion is a key element of burnout. Reviewing the evidence on staffing levels suggests that while you can get poor care with good staffing levels, I've argued, and I think my colleagues in the unit would agree with me who've done much more work on this, you can very rarely get good care with poor staffing levels. And I have said this at every opportunity I can, and we've sent our evidence to the Secretary of State, and we're lobbying very, very hard to get safe staffing levels, at least, if not minimum nurse staffing levels, because I know from talking to nurses on the wards that it is a really, really challenged environment at the moment, and you cannot, I believe, give good care when you haven't got enough staff. So we're doing our best as a unit to get that message out there. And I was saying it again this morning in a meeting with CQC, the Care Quality Council, who I'm asking them to put it into their inspection regime, so that they're asking when they go round trusts, what is your staffing levels? And there is a very brave Director of Nursing called Elaine Inglesby, who I admire very much. She works at Salford Hospital, and she has decided to put her nurse staffing levels on the wall every day. And I think that is enormously brave, because she knows that she will not be able to meet them every day. But she said it's transparent, and then patients can see, and then we can encourage patients to ask the right questions. How many registered nurses are on this ward? How many patients do registered nurses look after? And they're important questions, I think. As you will see by this slide, which also comes from some of my colleagues' work, Professor Anne-Marie Rafferty, who is former head of school here. She did this study in 2006. With Linda Aitken, who's a bit of a guru on this work. She works in the US, and it shows the apparent relationship between high workload, so the number of patients each nurse looks after. As you can see, that goes along the bottom. So along the bottom, it's the number of nurses, number of patients each nurse looks after. And as that goes up, what you're seeing, sorry, it's very difficult to see with these lights, but what you're seeing go up is the pink line is emotional exhaustion or burnout. So more patients you look after, you get more emotional exhaustion and burnout. Job dissatisfaction is the yellow line, if you can see that, so that also goes up. And poor quality care is the black line. And I think we have mortality. Yes, mortality is there too. So we know from that work, and there's lots of evidence now from the US, that the more patients a registered nurse looks after, outcomes are worse for patients, mortality rises. So, my PhD was undertaken at the turn of the century, so this century, 2000, and in the last decade or more, I think it could be argued that the pressures and challenges on nursing have become even greater. There's an increasingly ageing population with even greater health needs and complexity, and with the need for cost containment, the so-called 20 billion Nicholson challenge that I'm sure many of you will heard about. David Nicholson has charged the NHS with saving £20 billion. There's a greater number of patients to care for. And we already know there's a reduction in the number of registered nurses. The numbers of training places being commissioned in London has reduced by 27%. So that means we are training fewer registered nurses. And that means in 3 years' time, there will be fewer registered nurses coming out of King's. And I know for a fact that already the local trusts are looking at how they're going to implement that. What are we going to do? And obviously what that means is that they have healthcare support workers to fill. They have to look at their skill mix. So there are fewer registered nurses doing the caring work. This is a slide that's looking at the workforce changes between May 2010 and July 2012, which I think reinforces this message. I don't know what you notice here, but what I notice here are that the full-time equivalent change in qualified nurses has diminished to pretty much the greatest extent, apart from in infrastructure support. And what you'll also notice, I don't know if I've got no I haven't, is that doctors' numbers have gone up. And there was a very recent report also showing that. So the second line down, you can see the number of doctors has increased by 7% and the number of qualified nurses has reduced. So this is an RCN analysis of national data, and the total workforce decreased by almost 21,000 full-time equivalent nurses since 2010. And then RCN suggests there are still 61,000 posts at risk. They suggest from this data that we face a looming crisis in nursing through the dual dangers of restricted future supply, what I've talked about in nurse training numbers diminishing, and an increasing demand for nursing care. So we're going to have fewer registered nurses, but actually an increased demand from our ever-ageing population. Moving on to the next study I undertook, this was my postdoc, which I did at London School of Hygiene and finished when I came here. Is another longitudinal study with a similar approach, but this time I didn't look at newly qualified nurses, I looked at nurses new to the trust. So when I started the study, what the trusts were saying were that what were senior band 5 nurses then, they were actually grade E, they were D and E grades in those days, they were failing to attract and retain those. So I did this study to find out what was going on there with this group of staff. Some were very experienced nurses, and at that time, many have argued we've had quite a boom and bust economy around our nursing workforce. We were recruiting a number of overseas nurses from India and the Philippines to top up the diminishing nursing supply before there were more nurse training places commissioned. So this was around 2004, 2005. And what I found from this study was that the nurses reported a lack of time for patients was a recurring theme, and a sense of overwork, so quite similar to the newly qualified nurses in the other study. Again, poor skill mix and the stress of having to support others, so managing a nursing team and feeling responsible for the care others delivered, and feeling worried about that and not feeling that was difficult. Nurses in this particular organisation didn't feel heard, and the nursing point of view was very much felt to be dismissed. And very much the idea that is in other literature, the idea of everything is translated through your line manager in an organisation. People don't leave organisations, people largely leave their line managers. And in this trust, there was quite a sense in some of these environments about a poor leader or manager causing staff to feel unsupported and undervalued, with little feedback and direction. So staff were saying, how's it going? And they'd say, well, I think it's all right, but I don't actually know because nobody's told me. I don't know if I'm doing all right at all. Quite a few people hadn't had personal development plans or appraisals. So there was a real sense of not getting enough feedback. In this work also, I drew on the literature around motivation, the idea of intrinsic and extrinsic motivation. Intrinsic motivation, that's from within you, as opposed to extrinsic motivation being pay and rewards, for example, like that. They were both cited at interview, but they largely focused on the intrinsic motivators, why people come in, a sense of altruism, wanting to give good care, all the data I had from my other study. And these were the things that reflected why people chose to become a nurse in the first place and reasons for working in the trust. And they talked about the importance of meaningful work, of feeling valued, having opportunities for development, wanting to improve practice, maintaining healthy relationships with managers and the rest of the team, and this idea of working for a larger good. These were all intrinsic motivators and things that got people up in the morning, coming to work, what they wanted to do. So from this study, this is where we got to at the end of my PhD. I added a few more things in terms of what makes a positive environment of care. So this is where staff feel valued and receive good feedback, where staff performance is well managed. Staff talked about feeling quite demoralised if there was a member of the team sort of dragging the team down, turning up late, not doing the job, and that wasn't being well managed. So it actually made everyone think, well, if they're doing that, why am I bothering? I could get away with doing things like that too. And where staff feel heard and that their voice counts. These were seen to be very, very important. The final study was undertaken here at King's, and it looked at the potential link between staff experiences of work and their psychological well-being and patient experiences of care. This idea that, happy staff mean happy patients, which has got quite common currency now. I think when I started the study in 2008, it wasn't so well accepted. There has been much work undertaken outside of healthcare, and as we know, many large companies believe that happy staff mean happy patients. The Disney Corporation for one, and John Lewis is another famous one in this country. John Lewis doesn't say customers first, they say staff first. That's their motto. They don't talk about customers because they know that if they look after their staff, good customer care will follow. And this study was one of the first to examine this in the NHS and to link staff and patients at a team and individual level. And we produce these Policy Plus briefings. Some of you may have seen, you can sign up to receive these in your inbox if you so wish, if your inbox isn't clogged enough already. But we produce about 8 or 10 of these a year, and we ask these sorts of questions drawing on our research. So this is one example: does NHS staff wellbeing affect patient experiences of care? And we give you a summary of the evidence and situate it in the wider context, and they're just 2 pages with references. So many people find those quite useful. Little plug for Policy Plus there. And what we did in this study was we looked at 4 organisations, so 2 acute trusts and 2 community trusts, and in those we had 8 case studies. And we went into those organisations and said to senior staff, we want a contrast. We want to look at what we called a low-performing microsystem, a microsystem being a sort of series of wards, so care of older people might be 4 or 5 wards, for example, and a high-performing microsystem. And high and low were either where patient experience was good or poor, or staff experience was good or poor. And the most interesting thing, I thought was very interesting, is that out of 10 or 15 people we interviewed, there was definitely convergence. People knew where the good places were and they knew where the bad places were. So they told us where they were and we went in there to study them. And we did lots of observation of staff working, we did interviews with staff, we did interviews with patients, we did questionnaires with staff and questionnaires with patients. And these are the areas we looked at: emergency admissions, maternity, older people, elderly care, hemato-oncology and so on, and then community nursing services. And we've written a number of papers from this work, which, you know, if you get in touch with me, I can send you, but I'm just going to give you a flavour of some of this work. This is a very busy slide. Take a deep breath. All you really need to notice is that the dotted lines are patient experience. So they're from certain, PICA is the National Staff Survey, and PEACH is Patient Emotional Experience of Care in Hospital Survey. And the hard lines are staff experience from their questionnaires. So we measured them on all sorts of things like organisational climate, local work group climate, job satisfaction, and so on. But what I'm wanting you to notice is how the similarities. So where there is a big dip in the middle, which is acute nursing service 1, one of the community ones, there is low patient experience, there is also low staff experience. Where there is a peak in haematology, there was absolutely excellent patient experience. Patients talked about, you know, it being a Rolls-Royce service, they were so well looked after, staff went out of their way. Staff experience was also good. The other challenging environment right at the end, it's slightly harder to see, but is the emergency admissions unit. And we've written these up as case studies and really delved into what was going on and what were the challenges there. So what we identified were that there was a relationship between staff wellbeing and patient experience, and we also identified that staff wellbeing is an important antecedent. So you need to have good staff wellbeing to enable good patient care performance. And there were these 7 staff variables that correlated positively with patient-reported good experience. So these were the things that mattered, and that was the local work group climate, what it was like to work on those wards. Co-worker support, were your colleagues supportive? Did they help you? Did they look after you? Did they listen to you? Job satisfaction is important. What the organisational climate was like, was it a good climate to work in? And low emotional exhaustion, so that's the opposite of burnout. Burnout is high emotional exhaustion, and the importance of supervisor support. Was your line manager and supervisor supportive? Yeah, sorry, it's a bit late. That's the bit I was trying to focus your attention on. So adding to this slide then, we've had 2 studies that have come out with these things as being important in terms of positive environments of care, and now I'm going to add some more from this study. So the importance of excellent team leadership, how important that was, supportive co-workers. Staff talked about being a family at work and how important that was for their well-being. Being in what's called a low demand, high control environment, so where the opposite of that is very negative, where you're in a high demand, low control, where you haven't got much control over your work and there is too much demand. And where there is a space and opportunity to process work challenges with colleagues. And I'm going to talk a little bit more about this. So, now drawing on work I've undertaken with other colleagues, notably a review of research from all over the UK and internationally. I'm talking about acute nurse care, nurse experiences of care. What has emerged, this is a Journal of Advanced Nursing paper looking at capacity to care, a meta-ethnography of acute care nurses' experiences of the nurse-patient relationship. What nurses aspire to across the board, as we found out already from my work, but this is drawing on other work, is therapeutic relationships with patients, to connect with them, to get to know individual patients, and to involve patients in their care. So there's a consistent picture of an ideal nurse-patient relationship emerged. And that's the ability to create these therapeutic relationships, and they emotionally impact on nurses. So the ability to do this has an impact on nurses themselves. So meeting aspirations for a therapeutic relationship with patients in practice is an important determinant of nurses' emotional well-being at work. If nurses can deliver care of a quality that matches their personal aspiration and is best for that patient, they experience feelings of gratification, personal enrichment, and privilege. If not, nurses experience moral distress. And there's the review found a difference. Where nurses particularly found moral distress was in caring for these groups of patients. So in caring for dying patients where they couldn't relieve patients' suffering, caring for patients with dementia, and caring for older people where there's not the capacity to provide adequate care. And we've all heard an enormous amount about that in the media in the last year or two. And the review also found a difference, and what one of the papers said, quite interestingly, is that I think it's like a plastic shield that you put up, and I think if you stick at it long enough and you're in the job long enough, it becomes a natural way. So the sense in which nurses have to protect themselves against this moral distress, and how you do that is putting up a persona or a plastic shield to protect your own sense of well-being. Whereas what I'm arguing in my work is that if we were able to have more supportive environments and the environments were better at supporting nurses, we may have to do this less because there would be less moral distress, certainly if we had enough nurses and there was safe staffing levels, as I've argued. And the review, interestingly, also found a difference between nurses experiencing intensive care and in general wards. Probably not a great surprise, but I quote from the paper, "The organisational conditions of critical care settings appeared best suited to forming therapeutic relationships, while nurses working on general wards are more likely to report moral distress resulting from delivering unsatisfactory care. General ward nurses can then withdraw from attempting to emotionally engage with patients. And as I've said, the things that are important are needing one-to-one relationships, more registered nurses, and a better ratio of patients to nurses. But I think the interesting thing we know from the wider literature is not only nurses who experience this, you're not alone, it's doctors too. And this was in the Boston Globe earlier this year, talking about what they said was an empathy gap in medical students, and so that stress can harden students' attitudes towards patients. And in that study, Hojat said, I could have written this myself, I think, medical students from my work come in with a lot of idealism, they want to be of help and service, and then something starts to happen when they're exposed to clinical care. Sound familiar? Hope you've been listening, because it should. So I think students in this study, what they found was that students often believe they have to maintain a distance from patients to protect themselves. They say, this is a quote, "It's time-consuming and physically draining to be involved in a very emotional situation." Absolutely. But what I'm arguing we need is for not necessarily staff to put up a plastic shield, but to be supported in giving this quite emotionally difficult care. And the author highlights what he calls the hidden curriculum, a little bit like my covert rules, but senior doctors emphasise that medicine is a business. This is in the States, but some of us might argue or think that we may be going down a similar route. The lack of positive role models may lead students to believe that the human connection is of little importance, he said. Students may select when to turn on their empathy switch and when not, and learn how to be efficient with their empathy over time. And going back to the study I was telling you about the link between staff experiences and patient care experiences, we've written a paper that I think captures this as well, this idea about being efficient with your empathy or learning to manage the situation. And we wrote this paper called Poppets and Parcels. the link between staff experience of work and acutely ill older people's experiences of care. And what we did is we drew on the unpopular patient literature here in writing up our Medicine for Older People case study, which highlighted how in poor ward and patient care climates, staff seek job satisfaction through caring for poppets. That those patients who are attractive to them in some way, who are favoured, leaving less favoured and often more complex patients to receive less personalised care. These patients felt like parcels. And so what we're arguing really is that staff made work satisfying by selectively giving compassionate care to the rewarding poppets. And it's interesting, I was talking to somebody else about this in Mental Health Trust, and they could definitely identify with this in a slightly different setting. And what we've talked about in another paper is in praise of compassion here we wrote, and we said, this I wrote with these colleagues, Jocelyn Cornwall, and this is my colleague Kieran Sweeney, who is a doctor who very sadly died, and the paper was published posthumously. And what we said was that we speculate that the target-driven atmosphere of contemporary clinical care acts both as an impediment to and a defence from proper consideration of the patient experience. And we also argued that really relating to patients takes courage, humility and compassion. It requires constant renewal by practitioners and recognition, reinforcement and support from colleagues and managers, and it cannot be taken for granted. So this is a quote from one of the doctors we interviewed in our staff experience, and what she said, Dr. P, she said, everyone will say you need to be good at communicating, you need to be good at basic science, but one of the main things I think you need is resilience, because you work in a job that knocks you down constantly. You've just got to brush yourself off, pick yourself up and say that was bad, that was awful, but here we go again. I think if you take it all home with you and if you take it all on board, you simply wouldn't be able to come back to work the next day. And I want to talk to you now about some interventions, and this is an intervention that I'm working with colleagues. They were originally at the King's Fund. It's just been set up as a new charity. It's called the Point of Care Foundation. I'm one of the new trustees, interestingly with Robert Francis, which is great to be working alongside him, taking some intervention and something forward. And we're looking to, the grant's due in next week, so I'm busy writing it. We're looking at a way of evaluating these Schwartz rounds. And they came out of the Schwartz Centre in Boston. And it's one intervention to support staff. And what they are, a multidisciplinary forum that happen once a month across, not always acute trusts, there's some going on. They were brought to the UK by the Point of Care Foundation. Weren't quite sure whether they'd work in a more reserved UK culture. Was everyone used to sharing their experiences as they were in the States? But the two pilot trusts, which were Gloucester and the Royal Free, found that actually that people were very happy to share their experiences, and that these were profoundly both moving, but they gave staff a space to talk. They're based on a sort of grand round idea where you talk about a particular patient or a particular case or a particular series of cases. I've sat in on some of these, and one, for example, was about a patient who they couldn't get her pain under control, and she screamed an enormous amount of the day, and how that made staff feel that they were failing. And what it actually meant staff did was avoided going to that patient because it was all too difficult. And so what happens in these rounds is that a team might talk about this case, how it made them feel. Doctors will talk about it, consultants, physios, the whole team talks about it. And it's a space for people to reflect and say, well, I had a similar situation 10 years ago, this is what I did. But I think also what it does is it role models to everyone that actually everyone finds this work difficult. Everybody finds the emotional labour and the emotional challenges of caring for patients in great distress and their relatives difficult. And I think we don't talk about this nearly enough, and there aren't many spaces to do this. And I've argued elsewhere, not very popularly I'm afraid, but I've argued about 12-hour shifts. And what I noticed was when I went back to practice, how 12-hour shifts had crept in, and that wasn't the norm when I was more regularly practicing. And what I noticed was a real dip around 5 o'clock. People were exhausted and had to kind of sit down and say, well, I'll have a little bit of a breather, completely understandably. But I've argued all sorts of things like, can we be tolerant and compassionate over 12 hours? What's happened to that overlap in the afternoon where there used to be 2 lots of staff, where you could get some space to reflect, where you could teach students, where you could do appraisals, where there was space to actually think about work and share experiences, and where staff have these half-hour breaks dotted through the day, where often you're not with your colleagues. Half an hour is not enough time to get off the ward or out of practice to have a proper break. So where do you process the stuff, the difficult nature of the work that we do? And so I've been drawing on some of the literature and thinking about these reflective spaces. What are other interventions? This is one. There are others. Mental health does it much better than acute care in terms of supervision. There's something called restorative supervision. Another colleague I know is investigating buddying. So the Samaritans, somebody else was telling me recently, they volunteered with Cruise, which is a bereavement charity, and they have to have supervision once a month, whether or not they haven't seen anybody. And she's completely shocked that as healthcare professionals and nurses, we don't have to do that. We don't do that. And the Samaritans have a buddying system to support staff. Largely, we don't do that in the NHS. Also, individual interventions like emotional resilience courses, mindfulness, but it's about both supporting individuals to manage stress and think about ways of managing it, but it's also thinking about how as teams do we manage this? How do we talk about these difficult things? And Schwartz rounds is one way. So if I get the money to do the study, we will see how effective they are and whether they do change. The idea is, from places that are running them, they're running hospices, they're running an acute mental health trust that works in a prison, and acute settings, is that they actually somehow change conversations in the organisations, they change culture. That's quite difficult for me to capture as a researcher and have attribution. I'm struggling with that in my research study, but hopefully we can get a good evaluation and get it funded, and we can understand this much more and understand how we have good interventions for staff. So back to Stafford Hospital, where we started. What does all this tell us? What light does it shed on the issues at Stafford Hospital? I think what I feel, having read the Francis report, is that this was the living embodiment of crushed ideals and covert rules. I think that it was absolutely writ large. And it was not, I think, as much as the media has portrayed it and some people have argued. Personally, I don't think it was all bad apples, this idea of a system with some rotten apples in it. And it was about individual nurses, necessarily. I think it was a system-wide failure that left nurses unable to do the job they came into nursing to do. And this is a direct quote from the first report. And this is a doctor in A&E, and he said, "I've never met a nurse who comes to work to do a bad job. The nurses were so under-resourced to give adequate care to patients. If you're in that environment for long enough, what happens is you become immune to the sound of pain. Or you walk away. You cannot feel people's pain. You cannot continue to want to do the best you possibly can when the system says no to you. You can't do the best you can." And this is Austin Thomas. I don't know if any of you were at the RCN Congress this year. Austin shared his own personal... he was the lead nurse for the Paralympics GB, and he's disabled, and he shared his own personal story of nursing care. He was involved in a 90-mile-an-hour crash on the motorway, the injuries of which would see him endure 30 operations, years of recovery, and countless stays in a number of hospitals and trusts. He gave a frank and honest account about the abandonment he felt on a general ward. It's very powerful. But what he also said, he talked about nurses, and he suggested 10% of nurses were good, 10% bad, and 80% indifferent. I think what I would say is that 80% were perhaps compromised or crushed idealists, and they had become indifferent through the system. He also said, if you send a soldier into battle without what they need, they'll get battle fatigue. Well, we as the nursing profession have got care fatigue. Not enough of us, not enough kit. 80% of nurses are so overwhelmed they haven't got enough left in them to smile. So based on my research, the question we should be asking is, how do we support nurses better so that they're not overwhelmed and don't become indifferent? And going back to Robert Francis himself, he said, these are his words, "I am concerned that the nursing staff in particular are thoroughly demoralised. I believe that many have adopted a survival strategy of going through the motions of doing their job as opposed to pursuing a much valued and necessary vocation. Urgent steps are needed to re-energise and focus the staff on doing what I'm convinced they can do well. They need to believe they are valued, that their professional views are respected and listened to, and that proper recognition is given to good practice. So while much of the Francis report highlights that there were definitely nurses that lacked compassion, he's very careful to point out that many were simply exhausted and just doing the best that they could. And they didn't lack the tools to do so, and that was namely sufficient staff, effective leadership, and that nursing staff were not listened to, even when some tried to blow the whistle. Some of you may have listened to Helen Donnelly, the whistleblower from Mid-Staffs. She's very powerful and has now become care quality champion for her new trust, helping staff understand how to blow the whistle and to some extent the consequences of that, which at the moment for her haven't been too bad. She has another job, but for some staff can be career limiting. So I think before we conclude from some recent recommendations that it's all going wrong in the recruitment of staff, let me remind you of the evidence from my research I've presented today. So in summary, what I've said is that students enter the profession to give good care, yet ideals, compassion and empathy erode and can become crushed in poor practice environments. There's a lack of staff, no role models, little support and preceptorship, and they contribute to this erosion. There are covert social rules that socialise new nurses into the culture of the ward, and that nursing staff largely are intrinsically motivated and they have an inability to provide good care saps their motivation. Indeed, when they cannot give good care, moral distress ensues. Nurses need to feel valued, listened to, and get timely and accurate feedback to feel engaged. There is a link between staff experience of work and patient experiences of care, and staff well-being is an important antecedent of patient care performance. So I asked, do we have the right levers in place in our system? And this is another quote from my study. When you're rewarded for doing or expected, what you are rewarded for doing or expected to do are all the procedures and protocols and not to have cared. So that suggests we certainly do not have the right levers in place. So I think we need to set minimum nurse staffing ratios, or at least safe staffing, as the Safer Nurse Staffing Alliance has said recently. I've also argued elsewhere that we need to increase remuneration for ward sisters and team leader roles. I think that's been largely undervalued and they're asked to do a very difficult job for very poor remuneration. Reward and value caring behaviours, encourage good role models, listen to staff and see staff experience as an equally important barometer of care quality issues. And incentivise the implementation of support systems for staff. Oops. Sorry. So I asked this, if the job is making nurses sick, why not fix the job rather than the nurses? And I just leave you with some acknowledgements. I owe a debt of gratitude to many, many colleagues and many people who spoke to me, not least the students and staff, professors and colleagues in King's, colleagues at the King's Fund and so on. So thank you very, very much for listening. I hope that was of interest.
Jill, thank you very much for a most inspiring and thought-provoking talk. And we do have time for some questions.
Yes.
And if you put your hand up, do you want to run up and down the microphone?
Sure. Well, what we'll do is, are there any questions for Jill Maben at all? If you just raise your hand and I'll read out the question again.
Comments either. If you don't have questions, it'd be interesting to think what you think.
There's a couple there.
I really enjoyed that lecture and you really hit the nail on the head. I really relate to what you said. What is the government doing about it?
Very good question. So your colleague said, I really enjoyed your lecture. You've really hit the nail on the head. What is the government doing about it? Unfortunately, I'm not in government. But I was very interesting, as I said, I was at the department this morning, and I think one of the challenges, for me, one of the issues is we have to have a very good and open debate as a society, I think, about what we want our healthcare to provide. We have one of the lowest expenditures on health in Europe, and yet we have a government who are about cutting taxes. I think if we want registered nurses and we want the care that we argue that we want, and we want nurses to be able to provide that care, we need to invest. We do not need to be making 20 billion cuts in the NHS, but that's a wider issue. But I don't think we're having honest conversations as a society about it. I don't think we're really being encouraged to think about this care deficit. And I also think that I use the analogy, if you see somebody doing a bed bath, you could see a healthcare assistant doing a bed bath, and you could see a registered nurse doing a bed bath. And to all intents and purposes, what you see is them washing a patient. What I argue is that what a lot of registered nurses' work is quite invisible. It's not made visible. It's difficult to quantify. It's difficult to count. So it's quite difficult to make a case, apart from in our research where you see mortality going up, for example. The case for having more registered nurses is quite difficult sometimes to articulate, because what one hopes in that bed bath is that the registered nurse is assessing skin, assessing nutrition, talking to the patient about who's at home, assessing cognition. And it might be that some very able healthcare assistants are doing that too. But there's a lot of assessing and a lot of thinking underpinning, apparently, the same task. And I don't think as a profession we've well articulated that enough. The government, I think, there's another response to Francis coming out later this year. And they are going to respond to every one of the 270 recommendations, or 290, I forget the number. They're going to respond to every one. And I've been talking to that team, and I've given them all the evidence about nurse staffing. And I think it will be quite difficult for the government. I think they're in a difficult position now, because they've made the NHS architecture quite arm's length now. They've kind of said, well, we're the Department of Health, we're kind of stewards of the system, but we can't mandate. So they cannot tell individual trusts that they have to. CQC perhaps could. So I think we're in it because of the new way the NHS is run. It's quite difficult to know. I think we might know what the levers are, as I've suggested, but it's quite difficult to know where to pull the levers now, because it's not necessarily in the Department of Health and it's not centralised anymore. But I've been helping them think about, perhaps you could talk about safe staffing, and the Safer Staffing Alliance have talked about no more than 8. Now, I think we would all agree with that. No more than 8 patients to a registered nurse. If you have any more than that, that's not safe. And we have good data and evidence on which to base that. And that might be more palatable than saying 4 or 5. Because the worry is if you set a minimum nurse staffing, that often becomes the maximum, it often becomes the ceiling. But I know colleagues in practice, when I've spoken to them, said, well, that would be wonderful. I wouldn't even mind it being the ceiling. You know, we're nowhere close to that. So there are real challenges, and I think it's a real challenge, and we're in a fiscally constrained environment. We're in an environment where we're in recession, and arguably there is not enough money to spend on health. What I think we should be doing is having a very honest conversation with society and the public about, if you want the care, you know, to be good, you might have to pay more tax. But how a government would be very brave to say that, I think.
The information and the data that you collected is really, really good. Do you think there's any way of the ideas that you kind of produced would be transferred and communicated to the public about kind of nurses starting with a good ambition, starting with that, and it's slowly disappearing? Because I think the public have got this view that nurses are just bad people.
Yeah.
Do you think that will ever be communicated?
Thank you. Did everyone hear the question? Can I communicate these messages better to the public? I'd like to think I've been trying, but perhaps not well enough. I try and send my work. I try and write for Nursing Times, HSJ, sort of professional publications. I think it's quite difficult. I think we're in an era where there is quite a lot of nurse bashing, and you will all know this because you will all felt it. And to be honest, I absolutely feel for you as student nurses coming into a profession where the profession is being pilloried very often in the media. And I know when I gave this talk in May, some first-year students came up to me, and I found it very dispiriting because basically one of them said, my local hospital is Mid-Staffordshire. And I cannot talk in my own family about how proud I feel to be a nurse, because that message cannot be heard in my own family, because they can only hear their experiences of the local community, and that her grandmother was cared for in Mid Stafford and didn't have a good experience. So I feel we've got in a position where we're actually fighting quite an uphill battle, and I certainly do try and write, and I try and influence opinion leaders, and I'm always sending my stuff and trying to write it and making it accessible. I think it does get out about there, but we're in a slightly Daily Mail culture where we're in a situation of, it's quite difficult to hear different messages. And I think we also need to get out some good stories, because absolutely out there every day there are amazing things going on that we rarely hear about. Hi.
I was just going to say, the RCN have been doing quite a big campaign like that, actually, trying to get stories. I suppose it's how you get it to a wider audience, but they've certainly been.
Yes, your colleague, I'm repeating these for the film too. RCN is doing a lot of stories, positive stories, and getting that out there to a wider audience, so that's certainly one way of doing it. I think it's absolutely an uphill battle at times, and I think as a society in all areas at the moment, there's quite a blame culture, and people want someone to blame, and so the idea that there are bad nurses and bad apples, of which of course there are, but a colleague this morning was talking about an organisation in the US where they have a particular approach. So if a patient dies, for example, and there was a mistake, if that mistake was willful and neglectful and was with intent, then that member of staff is punished. But if it was a genuine mistake, then there is actually a learning opportunity here. And organisations outside of health, the nuclear industry, the airline industry, for example, it's bread and butter to have failure as seen as a way of learning. And I think we've got into such a blame culture in the current situation, is that it's quite hard to have that. And of course it's very, very painful for patients, but when you read the First Francis report, there are relatives saying, if only people had told us what had happened, or there'd been some apology, we would have, there's a level at which we would have understood, but the lawyers in the trust were saying, cover up, don't say, this will be misleading. From my own experience, my son had surgery in Australia in 2000, and he was given the ward dose of radioactive material. He was 8. Yeah, it was massive. And that was awful, absolutely awful. Of course it was awful. But the way it was managed made me feel so much better. So the first we heard about it was the senior doctor took us into an office and said, this has happened. We're really sorry it's happened. It shouldn't have happened. Here's the head of radioactive medicine here to tell you why it happened and what he's going to do to make sure it never happens again. And we had a report, and it was completely open and transparent. There was no sense of whispering or anybody trying to cover it up. It was like, we have made a mistake. The system has failed you and has failed your son. My son didn't die. He may still have long-term effects from that, but it was managed in a way that made me feel completely different. Of course it was hideous and shocking, and I would rather that hadn't happened, and the investigation he was going to have couldn't happen because he was very radioactive. But it's about how we manage things, I think, and I think we've got into a slightly different culture here that is at times unhelpful. Sorry, I'm rambling and not answering the question, I think. Hi. Sorry, Mary.
When we consider the Francis report and the craft ideals and demoralisation of nurses as shown in your speech, how does that impact how King's College London teaches and furnishes the students of the future?
Absolutely, great question. Been talking to Helen about it, and there's a seminal piece of work done in the US in the 70s called Reality Shock, somebody called Marlene Kramer. And her findings were slightly different to mine, and she used different terminology, but essentially it was similar going on in the US as long ago as that. And what she talked about was an anticipatory socialization program, so that you were helping students think about these things quite early, giving them scenarios, what would you do here, helping people think about how do you raise concerns. Mary and I are doing some work very soon with some focus groups of students about whistleblowing. We're working with somebody who's creating a whistleblowing guide for students, and we're going to talk to students about what are the issues for them, what are the challenges, and so on. So I'm talking with Helen, I'm talking with colleagues about thinking about this in the curriculum. One of the challenges, of course, is the curriculum is very full, and we have NMC regulations, but Helen is very minded to support us thinking about this, and it'd be great to work with some of you and talk to some of you about what that might look like and what would help you think about these things, and how perhaps, because everybody needs to be socialised. I'm not saying you don't need to be socialised, but it's how perhaps you resist some socialisation, and what my people in my study did, they kept job hopping really to find an ideal environment. And some job hopped and found one, but other people just went and it was a different set of issues. So people thought if I go to the community it will be better because I'll have one-to-one with patients. Actually it was just different. There were different things going on with there. So how do we help staff have both resilience, think about organisations, questions to ask at interview, issues about preceptorship, but it cannot only be your responsibility, it needs to be an organisation-wide responsibility, I think, and we need to take some responsibility, as you say, as King's College London, to take this forward. So ideas very welcome about what that might look like on the curriculum, what would help.
Jill, I really enjoyed your speech, and
Thank you.
glad I was able to come.
Thank you. Mary has come all the way from Ireland, by the way. She's doing a PhD.
But I'm actually shocked to hear that they're reducing the students by 20%.
27.
Pardon?
27%.
I mean, that's just gobsmacking, considering the data that's there over the last 20 years.
Absolutely.
And indeed in the States, where they had huge problems in the early noughties, and they've now, at last, the data is starting to change. They've increased their student ratings and their student numbers. I mean, why isn't the government listening to that? I don't understand that at all.
It's interesting, isn't it? I had a senior civil servant this morning talking about how to get evidence into policy, and how it's difficult because politicians have a particular way of thinking often, and the evidence doesn't always suit the political cause. So I think it's also to do with bankers, fiscally challenged environments. We did have a big investment in nursing under the last government, but that government also took us down a purchaser provider route. So I don't know is the answer. That's my frank answer. I don't know. As a producer of evidence, I would love them to listen to all the evidence, and I do send it to them a lot. And my own view is that you keep chipping away, and you drip, drip, drip. And I've been saying this for a long, long time now. And finally, what I'm heartened, I mean, it's interesting because everyone thinks, well, we've always known staff experience is linked to patient experience. And I'm going, hang on a minute, we didn't always know that, and we certainly didn't have the evidence. But the fact that people think it was well known, I think now is a good thing. And that's taken as granted. So it's a way of getting evidence into practice in a slightly different way. And I think things become recognised, and I think there is definitely a recognition that supporting staff makes good business sense and is something that should be invested in. Making every place do it is another matter. And as I said, the levers in our system, in England anyway, are different now. We don't have the same levers to sort of, the DH, even if we were to influence them and they were to listen to evidence, they cannot influence what foundation trusts and others do in the same way that they could. So that's a long way of saying it's tricky. And I would love it if they listened to lots of evidence.
Jill, once again, thank you very much.
Thank you.